Hello and welcome to the Two View, the cutting-edge educational interactive show for PAs and nurse practitioners in emergency medicine and urgent care. My name is PA Michael Sharma, and I practice emergency medicine urgent care in Dallas, Texas. Usually, I would be introducing my co-host, NP Martha Roberts at this time. Martha's been called away for this episode, and we can't wait to have her back for the next episode. But in her place, we have the co-director of the original emergency medicine boot camp, the founder of the Center for Medical Education. It is Dr. Rick Bucata. Rick, it's such a pleasure to have you on the podcast.
Well, I'm happy to come out of the bullpen with little notice, but I think I can save the game here. I'm not so sure, but who knows?
I'm really looking forward to it. I think it's going to be great. I mean, like we were talking about before we recorded, you're no stranger to the podcasting world and to the asynchronous medical education world. You kind of started it off with Dr. Jerry Hoffman. And so it's a real pleasure just to be with one of the godfathers, so to speak, of the art form here.
Well, you're very kind. More than deserved, but still very kind.
Well, I think well-deserved. Well, as you know, we just parted ways in Las Vegas in person. We just come back now from the original emergency medicine boot camp's July running. It was amazingly, I think, hotter than it is here in Texas currently, but it was a great time to get the band back together and talk about the core emergency medicine content. Rick, how was it for you compared to the 20 or 30 one of these, if not more, before this?
Oh, well, we've been doing them since for about 9 years now, actually, maybe 10. And every year there's a lot of energy. One of the things I think is unique about PAs, NPs coming to school is that you can see their energy for wanting to learn. Their passion, their enthusiasm is palpable. And that really makes the courses a lot more fun because they're engaged. I mean, it's like they're almost getting prepared to take an exam because they're writing notes and they're looking and they're listening, and it's kind of like it's pretty intense experience, and I really liked it. I enjoy it every time we do it, and we also have other people there. Like we have a good number of physicians who are in their second specialties. They were retired surgeons working out in rural America. The physicians, family physicians who also are in private practice, but they also cover the ER in rural America, and we have a goodly number of those as well. So it's a mixed group. So, and the other thing that's mixed about it is their experience. Some are new grads, some have been around for a long time. So it's always kind of a little hard to make the balance between, oh, that's too obvious, or no, it's not. So we kind of walk a tight line trying to find what would be the best and most interesting and high yield content as we can find.
I think it's important just to go back to the basics sometimes. Some of those things that we thought we knew, and we thought we knew why we knew them and why we do them. Sometimes, on retrospect, we do these things for the wrong reasons, or the evidence behind them is not as solid as we thought it was when it was taught to us. We are products of the people who taught us, and they are the products of the people who taught them. And sometimes things sneak in along the way that they need to be weeded out. It's up to us to kind of be always filtering, always reevaluating. I've been looking forward to the camp all year. It delivered on all my expectations. And I think everyone there at the camp said the same thing. They love teaching at boot camp, regardless of how this may be considered like entry-level emergency medicine, the core content. But it's because of the attendees. It's a great environment where everyone is there to learn, to think through these topics, to ask great questions, and to have a lot of fun on the conference floor and also out on the Vegas Strip too.
Yeah, there's actually no way you cannot leave this course learning a substantial amount of information. Some people will learn more than others, but everybody's going to come away, because you're right, evidence changes over time, and the longer you've been out, the more you may be away from the evidence. And we want to hold people's feet to the fire and say, show me that's the answer, prove it to me,
Right.
Just because you say we've always done it that way, that's not going to work here.
That didn't work in the military when I was a soldier. That doesn't work in medicine either. No, that's the worst reason to do something, in my opinion. Well, we are going to do something a little bit unusual for this episode here. We're going to recycle or bring up an old staple of the entertainment industry. It's the clip show. Now, what a clip show is when someone recycles content that was previously aired and kind of does a little bit of a riffing on it. But what you're going to be hearing is brand new to you and the listeners of the Two View. These are recordings of talks that Martha and I have given live in Las Vegas. And then Rick and I are going to kind of interject here and there and spend a few minutes giving our thoughts on these sound bites.
You mean like this is summer reruns?
I prefer to think of this as repackaged, repurposed. It's new to you, kind of a thing, you know. So yeah. So if you want to call it reruns, you can belittle it, I suppose. But after that, you're going to hear a live Q&A session from our 2021 boot camp. And you know, I say that I learn something new every time I go to the boot camp, and it's not always from the material presented, but it's, you know, someone puts forth a thought-provoking question, a new wrinkle on a situation that I've seen before. And having these questions is really great. And it's a real privilege to be able to ask questions directly to people like you, Rick, to your co-director, Dan Burbaumer. You have Ken Milne, you have MRAP faculty like Britt Guest and Jesse Warner, Jen Schoenberger, who runs the residency out at LA County, USC, Michael Juch, Chip Lang. These are, you know, rock star NPs and PAs who teach and do podcasts of their own right. And so it's just, you know, you sometimes you're listening to a podcast or you're reading something, you go, gosh, I wish I could just ask the person who wrote this a question. Well, you can do that at the boot camp.
Okay, so time for a segment.
Yes,
this is Martha giving her bits and pieces.
Well, she calls it odds and ends, but
yeah, actually, I realize bits and pieces is a kind of like, if you're in England, that's a reference to some genital kind of thing.
I thought that was twigs and berries, but yeah, whatever, something like that, right?
Bits and pieces, okay.
Fish and chips, something, something and something else. Okay, so yeah, so we're going to talk about that right now. The next voice you hear is going to be my co-host, Martha Roberts.
So as Diane would mention, for the vital signs, did you go back in the room and check the vital signs? How did they look? Did they improve? What is normal? What is abnormal? Do your critical thinking skills, not just when you first see the patient, but when you're also discharging the patient. What might you have overlooked, right? Have a little checklist for yourself. And then what did you find? And you need to communicate that to your patient. Now, what happens if you have incidental findings? And we did briefly discuss this. What I like to do is if someone has an incidental finding, pulmonary nodule, something else that they need to follow up with that may not be an emergency today, they need to have it on a sheet of paper, you give it to them and highlight it. Now, an incidental finding saved my life from one of my favorite ER physician friends many years ago. I went to the emergency department. I had a horrible headache. It was the worst headache I've ever had in my whole life. And I got the whole workup of the CT of the head and the neck. And I ended up being fine. It was migraine. It was just really severe. But I remember my physician came in, who was my friend, but also does this for every patient. And he said, you know, I found something on your CT. It looks really normal to me, but the radiologist really, I think it was an overread, maybe, I'm not sure. But he's like, I'm just gonna, you know, go through this with you. And I had a mass in my neck. So I followed it. I didn't make a big deal about it, but I mean, tons of times there's incidental findings that are kind of overreading or hedging by the radiologist, and we don't really think much of them, right? A couple years later, I went back to the doctor and said, you know, hey, I got this piece of paper that says this information, you know, what should I do? I ended up getting more imaging on my neck. It turns out that I, you know, had a big growing tumor in my neck. I had a big Hürthle cell tumor. And for any of you that have seen my big scar, it's a reminder that that ER doctor ultimately saved my life many years down the line. So I'm very grateful to him. So the other things that are really important is setting up appointments for your patients. Now that seems like a real big pain in the ass, but I'll tell you, once you work in a place for a long time and you start seeing that primary care doctor's name on the patient's chart, it's really easy to call the office and say, so-and-so is here, you know, I'd like to schedule an appointment for them. It's easier than you think, and there's always a backline for the office.
So we just heard Martha talking about her approach when we're about to discharge a patient, and you know, it's really important, I think, to do that last, you know, at least walk by the room before you hit print and walk in with your discharge paperwork to tell them how good they look. Rick, what was your practice back in the day when you were about to discharge a patient? Was there any sort of checklist that you had?
Well, I did something that was kind of weird. I discharged the patients by myself.
Oh, wow.
Yes, that wasn't, oh wow. Because oftentimes I would see a person and they were just kind of leaning against the door sill. They're all fully dressed, and I watched one guy one time. He stood there for at least 15 minutes. And I said, "What are you waiting for?" He said, "Well, the nurse needs to sign me out," kind of thing. I said, "Geez, I could have done that." So I also thought honestly that it would be the most effective way to discharge a person, because this is the last chance you're going to get it right. So this may be do you have any final questions or of anything like that? And they said, oh, by the way, did I tell you that I had a splitting headache yesterday? You know, when were you going to tell me that? It's like, so the idea there is to see if you can get a little bit more information, make sure they feel okay, better than they came in, that their vital signs have been checked and that you can explain the abnormalities. You don't have to wait till a kid who has 103 temperature has a 98.6 to discharge him. That's ridiculous. Although some places do that. But you just need to know why they're having it. I feel comfortable, and with the medicine that we're going to give the child, it's going to come down. But we don't have to wait for it to come down. It's not like, well, if it comes down, it's a viral illness, and if it doesn't come down, it's a bacterial illness. None of that matters actually. So yeah, I think you take the vitals. You may find the person's incidentally got high blood pressure. It's like they're there for a sprained ankle, but we take the vital signs, and so it's a test. And like if the test is abnormal, then you have to respond to it. Blood pressure is 155 over 92. That's abnormal. You're obligated to respond to this abnormal test. So you just basically say, listen, while you're here, we checked your blood pressure a few times and it was always a little bit up. I'm going to advise that you tell your family doctor about that. And I'm going to put it down here on your aftercare instruction that your blood pressure was a little bit elevated. Maybe when you go back and get a recheck, it'll be fine, that kind of stuff. So you'd reassure them, they don't necessarily have high blood pressure kind of thing as a disorder. And I think that if they have any questions, I think you want to be the one to consistently give the answers. Like somebody says, you just stapled their head up. And you say, well, when can I wash my hair? Well, I've heard people say, well, keep your head clean and dry and until we take the staples out. I mean, I'm not going to wash my hair for 7 days. It's like,
that's the worst way to get an infection more than anything else, I feel
Plus you'll have no friends. Can you imagine this concrete ball of hair up there now? No, of course not. You go home, you can wash it tomorrow. As long as it's sealed pretty well, it's not going to get infected. It's really hard to get scalp wounds infected. You've got to put warm steaming manure right in there and sew it over quickly, and maybe then you'll get a scalp infection. But they don't occur. So yeah, I think it's important that the doc or whoever took care of them, the primary care person who took care of them, sign them out. And if you're not allowed to do that if the nurses have to do that process, well, it's just redundant work, frankly. And I think you're in a better position to answer questions than they are. They're going to give the answers that they like to give, and the answers that some other doctors give. Well, I like to give the answers that I thought I would give, because I'm trying to get responses that are as evidence-based as possible.
Yeah. And it's nice too, but sometimes you can even do that in the room with the nurse. And, that way the nurse, the patient are all on the same page. When the patient leaves, there's no confusion on anyone's part as far as what was discussed on the way out the door. I have a real big heart for the incidental finding on radiology. We're going to miss some of these kind of like probably, hopefully benign incidental findings in terms of printing out the imaging and giving it to the patient and stuff like that. But both of my parents' cancers were diagnosed on incidental findings. My mom went in for appendicitis. She happened to have this apple core lesion they also saw on her colon, and she ended up having colon cancer. My dad went in for some belly pain. They CT the abdomen, but as you do, you catch a little bit of the thorax on that, and that led to the discovery of mesothelioma. And so I'm very thankful to the incidental findings, and that the clinicians on duty that day took the time to print those out, to share those with me, with my parents. And I think it's important too, like you're kind of on the hook for these things. Like she said. So what I have taken to do is there is a diagnosis called abnormal blank, whether it's CT, ultrasound, x-ray. I will diagnose them with that. I will give them a copy. I will write in my discharge paperwork that they get, and in my MDM saying, we talked about this abnormal finding, please follow up with so-and-so. And that way, all the I's are dotted there, and there's no question that you had this discussion with the patient.
This is prior to the electronic medical record, where the family physicians would have access to it, but I would send everybody home with an envelope that had your the EKG in it, your report of your X-ray, your CBC, your electrolytes, all that would go into a envelope, sealed. Say, hand this to your family doctor when you get to see him. Right. This way, we would basically have all of that work just handed to them, rather than I got to look at my computer. So that was done before. Now the physician should be able to pull it up, assuming that doctor's like in network and has access to the ER record as well, which may or may not be the case.
Well, thankfully, a lot of these hospitals have portals now to where, the patient can pull up their record from when they were in my ER. They can show the physician, from our medical records. So it's important to know that if your hospital has a portal, the notification for the patient that there is a portal is buried on page 7 of the discharge paperwork. They don't know until you tell them there's a portal. This is how you get to it. So I like to front that on the first page of the discharge instructions. Go to the portal.
Well, the 21st Century Cures Act now allows patients ready access to their medical record. And so it should teach that should teach us that we should maybe be a little bit more careful with how we document. As an example, we say patient complains of.
Oh yeah.
And they read the record. I'm not a complainer. That's just our lingo. So if we said the patient presents with, then it makes it sound much more acceptable, kind of thing. We don't say the patient's sick. We don't say the patient's a sickler. It's a patient with sickle cell disease.
Yeah, of course.
So that we, take the dehumanization out of the process as much as we can. We don't say morbidly obese anymore. You have to say something that is, a BMI 3 times normal. They don't know what that is. Maybe that's pretty good. Congratulations, 3 times normal. So because of that, you don't want people reading your record, and also you don't want them reading the record and find out that you have documented things that you did not do. He never asked me about whether I smoked or not, or those kinds of things, because now we have this idea that we're going to do 8 of these and 15 of those and 4 of those, and that if we do that, we'll get level 5 even, and so it's kind of like the big lie. All other systems checked and negative. That's a lie. You didn't check all the other systems; they're not negative. So I think that we have to be careful. We have to be truthful. There was a study done at UCLA with 9 residents doing physical exams, and they all basically put down more history than they did in terms of checking boxes, and more physical than they did, every one of them. So it's an easy trap to fall into, but now people are going to be looking over your shoulder. So you got to be careful.
Well, speaking of that interplay between us and the patient here, Martha's next segment is going to be talking about kind of like a teach back, making sure that when the patient walks out, that everyone's clear on what has happened during that visit, and how to know that the patient is clear on that before they leave. So let's cut to that.
And then, of course, do the patients have any questions? Answer their questions. Don't just breeze by the door and say, hey, everything looked fine. Got any questions? Okay, bye, right? We need to make sure we go in and talk to them. And the way that we talk to them is really important. We don't talk at them. We ask them to talk back to us. And that is the Ask Me 3 approach by the National Patient Safety Foundation. They essentially say, please ask your patients the following 3 questions. If you do and they can answer them correctly, they more likely will do better upon discharge. So you have them say, what was my main problem? Well, I was here today because I had an abscess. Okay, then have them say, what do I need to do? Well, I need to come back in 2 days, right, you said, and have the packing removed. And I say, yep, that's right. And then ask them how they're going to manage it at home and if they run into any problems. Well, if I have any problems with my abscess, and then they might say, I'm not really sure. You say, I want you to come back right away, especially if you have a fever, and that's when you can interject. It's a conversation. And then lastly, you want them to tell you why it's important. Why would they even care to do these things? They need to communicate with you why they think it's important and why you think it's important. 40% of patients are unable to describe the reason for their hospitalization. Oh, I went to the hospital. I don't know what my problem was. They said there was nothing wrong with me, right? But we all know that we do more for patients than that, right? At least I hope we do. More than half of patients can't even recall the discharge instructions or their follow-up appointment. That's our fault, right? So in some cases, yeah, you can't teach patients. You might tell them again and again and again. And so I understand that it's difficult, but in the end, it's our job, it's our responsibility to help these patients navigate. Of course, there's going to be a patient that you know what, it's a tough day for them, but we do the best that we can. So work on these teach-back techniques. They're very useful. And then also the Society of Hospital Medicine has a checklist. You can check that out as well. What should be on the paperwork? What's important? Well, a lot of things. We got to put the patient's name. We got to put your name or the physician's name. We need to put the purpose of the discharge instruction. Well, they were here for such and such, and they got a diagnosis of blah, right? So potential complications need to be listed, as well as medications and side effects. Now, I don't particularly love the medication printouts that come with our paperwork, and every institution is going to be different, but I'm going to show you some smart phrases that you can literally directly copy and use if you like. I've had them all reviewed by JDs, MD JDs, to make sure that they were A-OK. You also want patients to have a follow-up plan, which I'll show you, and then documentation that they receive the information. And people are like, well, hey, what if they don't take the paperwork? What if they throw the paperwork in my face and say, screw you, you didn't help me at all, right? Well, hopefully that's not the situation, but once in a while it happens. Well, you do your best to document that you went over the information with the patient refused to take the paperwork with them. You can also attempt to mail the paperwork to the patient. I worked in an institution that emailed the paperwork to the patient, didn't even have paperwork at all. If they didn't have an email, then certainly we printed it off for them. The other thing I like to tell people is I give every patient my email. When I started telling people that at prior courses, they were like, oh my God, why would you do that? Well, you know what? I give my patients, hundreds of patients, my email. Maybe for every 100 patients, one writes me. Maybe once in a while I get a really nice letter that says, hey, this incidental finding ended up being nothing, but thanks for, helping me get this appointment or whatever. It's so gratifying to know how some of your patients do. And also, if you can fix something very easily in just 1 to 2 sentences in an email, I'm not talking about like the patient writes you and says, I have chest pain, what do I do? They're like, hey, you said you were going to write me for 7 days of Keflex, but the pharmacy says they only have 5. Now, what if that patient just decided to come back to the ER and go through all of that? To me, if I can take care of something that easily, I do it. Now, of course, everyone's schedule is different. You shouldn't have to be on 24/7. This is just something I do, and my patients really enjoy it.
Rick, for you in doing things like teach back, I mean, I don't know about you. I frankly don't have the time to do such a regimented teach back for every single patient. Are there any patient presentations in particular that you think a teach back is appropriate to do on or even necessary to do on?
I've always struggled with that. I thought it was, when it was explained, well, you tell them, and then you get them to tell you what you told them back. I thought that was kind of like a little bit demeaning or embarrassing. Right now, you tell me what you tell me what I just told you. So I think that I wasn't a big teach back fan, although I know everybody says that, but I think if you can do it once, and if they allow them any questions, and much of the time is straightforward. Plus, we had on our discharge instructions, if you have any new or worsening symptoms, come back to the emergency department immediately. New or worsening. There are three things that can happen to a symptom. They can have new, now I'm vomiting, or now I have fever, now I didn't have that before, or worse, now the pain's killing me, or it's lasting too long. Like my sprained ankle is lasting 3 weeks now. That's too long. So, but that's really much more difficult to deal with. But new worsening, come back immediately. Basically, I don't want to list all this litany of all these kinds of things and teach them all about head injuries and, those kinds of things. I don't want to do that. I wanted to say, your headache's worse, come back. Certain vomit, come back. It's like, I don't really care what is the new or worsening. I just want them to come back. I don't feel comfortable necessarily sending them to their family doctor, because what if the family doctor, they call the family doctor and they can't get an appointment for 2 weeks because they didn't explain they were in the emergency department, that there's some urgency about this. So I want them to come back. They're my case. They're my patient. I want to see them if things are not going well. And I think that the idea of newer worsening allows you to kind of, you can put other things down, like more specifically this or that. But this idea of going out with this 1/4-inch thick thing of paper is just like ridiculous kind of thing. They're not going to read it.
Yeah, I think Martha's like kind of more talking about the highlights here, like the kind of what you said, like, what am I going to do if it's new or worsening? And the patient goes, well, I come back. Yes, exactly. That's what you do, is you come back. So I think that's kind of where she's at. I've used Teach Back for some of our, we call them familiar faces in our ED, the ones that keep on coming back for the same complaint. It's like, let's really make sure that it's clear what you do next time. Or sometimes where there's even been kind of AMA type situations where it's just not clear whether the patient understands the gravity of what's going on with them. It's like, oh, you've got this crushing substernal chest pain that started as you were, mowing the lawn, but you really want to go home after, you have this funny EKG pattern. I want to hear from you. Like, what are you understanding is going on here with you? What is your concept of what's going on? Why do you think we're asking you to stay longer? Just so I can kind of gauge the patient's perception. And I feel like that's, you can tell me maybe not, maybe somewhat protective if the patient goes, look, I understand you're telling me I probably am having a heart attack right now, and I understand it could kill me, but I have to go home for XYZ. And that's something I can write down and say, look, the patient clearly has capacity to understand and make medical decisions, and he's choosing to leave. And I'll write something and I'll verbalize it to them, and I'll write it down saying, look, we part as friends. This is not the end of the relationship. If you go to the parking lot and you say, oh my gosh, I made a horrible mistake, you just come right back in. We won't charge you for a second visit. We'll just get you right back in. So we love to have you back anytime. I as much as I might be feeling some kind of way during those contentious talks, I can't show it. I can't demonstrate that to the patient.
Yeah, you can't make it. You can't shame them in coming back. They basically have to be welcomed back. I'm glad you came back. And the other thing is, some people say, well, okay, so I may have had a heart attack. Well, that's okay, but but did you know you could die? I just thought it was a heart attack. So I think that you have to basically say, you may be having a heart attack, and frankly, one of the consequences is you may die. Everybody understands die. I got it, die. And hopefully somebody's in the room with the person, so that you're talking in a 3-way or 4-way conversation, so that there's everybody is understanding what's going on. Oftentimes when that happens, the spouse will say, listen, you're not coming home if they're thinking you're having a heart attack. I don't care what you say. You're staying, Charlie.
Yeah, I like that. I like getting family involved when it's appropriate, especially if they're in the room, or if it's like, hey, who's at home that can watch out for you? Your daughter lives with you. Hey, that's cool. Well, look, can we talk to her real quick, just so it's clear that they know what to do when if you go home and things get worse. I love to talk to them and see what they have to say. Make sure they're aware as well, and then you can include that in your documentation of the situation.
Technically, you have to ask the patient if it's okay to
Oh, of course.
bring your daughter in, because we're hyper vigilant now about protecting everybody's privacy. When in the past, family would just kind of wander in or out, kind of thing, and you just kind of assumed that their family would want to know what's going on. But anyway, now it's a little different. But I think aftercare instructions are really important, and because if they're really important, that's why I want to take 3 minutes and do it. I want to do it, and if there's paper to be handed out, I'll hand it out. But yeah. I know that that's probably not likely to occur in most emergency departments, but they have this process which is tedious of getting it out of the department. You have to. It's like we should work more at getting efficient systems to get people in and out, and we're not particularly good at that, honestly. Everybody knows when you come to the ER, prepare to wait, bring a lunch.
Right. Even if the patient encounter is done, all right, well, registration is going to come talk to you, and you'll probably be out of here about 20 minutes from now, even though the reason you came for is already concluded.
Right.
How about email or other contact info to patients? I know this one, it really could have bit this patient in the butt, and I'm glad that I was just available. I put a patient recently on Paxlovid. And as we know, for COVID-19, there's really some strict guidelines here. The patient's got to have certain patient factors going on. They can't have kidney failure, liver failure. Medications can be contraindicated relatively absolutely. And there's a time crunch. They've got to take the medication within 5 days of onset of symptoms. Well, I sent this patient out with Paxlovid after doing a very thorough med rec on them. And the urgent care I was in is shutting down for the day. And as we're shutting down, the front desk lady says, hey, CVS just called, but I wanted to go to voicemail. And I was like, I better get this. And so sure enough, it was CVS saying, hey, we're not prescribing Paxlovid to this patient until you do XYZ with them. And I had already done that with the patient, and the pharmacy was going to get in the way of me rightfully prescribing to this patient. So thankfully, I was able to call CVS and say, look, we already did the med rec. We already got, cleared kidney, liver function here. Please release this medication. The patient's there at the pharmacy wanting to start their treatments. And so I think that there are certain cases in which, yes, some sort of email or other contact info is really important for these time-sensitive things.
Although you have to be careful about leaving messages on their answering machine. If they have such a thing,
Yeah, there's I always able to talk to the patient directly, thankfully, talk to CVS directly, the pharmacist, then talk to the patient. I've also I've written in the discharge paperwork that I've given to the patient. I've said, hey, if you need to go to the pharmacy, or if you need to contact me, I will call. If I don't get you, I'm going to leave a voicemail saying, hey, call, or hey, go to the pharmacy. And we talked about that, and you said that was okay. And I think there's a good medical legal argument to be had to where the patient signed for receipt of these papers, and it said on there that I wasn't going to make this phone call. You can document in the MDM as well, saying you had this discussion. I think that's a way to kind of, if you want to say, get around privacy issues, or just kind of account for them, whatever phrasing you want to use there.
Yeah, I think you can call the patient, but you just can't leave a message that the gonorrhea test is positive.
Right.
That's all.
You got that herpes, Mrs. Johnson. I'm really sorry about that. Okay, well, that was great from Martha. And I think, again, it kind of hammers home the point, and there's more she has to that talk as well about how important it is to end a visit properly, including with your documentation, discharge instructions here. We're going to flip it to one of my talks now about upper abdominal disorders. And we're going to listen about how important it is to, make sure that what you are evaluating for is what's actually going on and the dangers of problems in the upper GI system.
Let's talk upper abdominal disorders. This one's a banger right out of the gate because so many things can go wrong in the abdomen. Now, when you talk about upper abdominal disorders, it's very important to not confuse it with things that present with upper abdominal pain. Because look superiorly and inferiorly from the upper abdomen, and what do you have? You have the heart, you have the lungs, you have the lower abdomen where that dang appendix sits and the bladder sits, right? So please, 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 if I can impress 3 things upon you during my talk today, the first one is this: keep a broad differential diagnosis when someone comes in saying, I have upper abdominal pain. I will never forget this appendicitis I took care of, this lady with appendicitis. I didn't take care of her appendix, I took care of her. She comes in saying, I'm having 6 hours of upper, like epigastric abdominal pain and nausea and vomiting. Now, if you work in like a provider and triage model, how many of those patients have you seen and discharged out of provider and triage? Here's some Bentyl, here's some Zofran, here's your discharge instructions for your 6 hours of nausea and vomiting in this young, healthy lady after a negative pregnancy test, right? I was in fast track. This came to fast track for me. I gave her some medicines. She was pretty benign as far as her story goes, pushing throughout the abdomen. A little right lower quadrant tenderness, interesting, but predominantly upper epigastric tenderness here. She's not feeling better after a half an hour of Bentyl and Zofran and some time. And so, second point I want to impress upon you for upper abdominal disorders here is doing serial exams. You think it's something, do something about it, and then recheck them after the meds have kicked in and see where they're going. So I do a serial exam, and she goes, yeah, I got a little better, and then I started feeling worse again. And this was only like 45 minutes after the Bentyl had gone in. And I'm like, all right, something's wrong. I don't want you to go home because I think something else is going on here. I think you might have appendicitis. She goes, no, I think I want to go home. I said, okay. Here's point number 3. You have to give clear, timed follow-up instructions that are appropriate for the condition. So I told her, I said, I need you to come back when you're worse. And not in whenever, not in 3 days. If you are not better or feeling worse within 8 to 12 hours for this person with new abdominal pain, if you're not feeling better or if you're feeling worse in 8 to 12 hours, you need to come back to my ER. She rolls back in 6 hours after she leaves AMA, tachycardic, febrile, with a white count of 7. So you can't just draw labs and go, oh, the white count's fine. 10% of appendicitis patients have a normal white count, and she gets her appendicitis taken out. I'll never forget that. And that was upper abdominal pain, okay? So don't confuse upper abdominal pain with upper abdominal disorders, which we're going to talk about today.
Okay, so the classic abdominal pain conundrum is the problem anatomically where the patient's pain is. I've got another story right here in my text messages that I got recently from a colleague of mine. I'll just go ahead and read it, de-identified. Mike, a patient came back in this evening specifically asking for you. The front desk lady knows the name. I talked to him briefly. You wanted to come in and thank you for probably saving his life. You sent him to blank last week with right upper quadrant pain, but mentioned this could be his gallbladder, but could also be a pulmonary embolism. Blank did not work him up for PE and said he maybe had pneumonia on CT on lower lungs when they were looking at abdomen. He persisted with his primary care, who ordered a non-contrast CT, but when at the imaging center, he asked if he could please get a CT angiogram instead because you had mentioned a PE. He is now diagnosed with his PE and on Xarelto. He is very thankful to you and wanted to let you know in person. So, Rick, I'm sure you have dozens more stories where, some other complaint masqueraded as upper abdominal pain.
Yeah, that's one of the harder ones, actually, because we know down in the lower part of the abdomen, we can increase our likelihood of having something surgical. But in the upper abdomen, one of the things that we still have on the top of the list for cases where we're getting sued is right after strokes is still myocardial infarctions. And despite the fact that we have all of these good pathways, we still, make mistakes when we think the problem is abdominal when it really isn't. So I think generously getting EKGs is generally a good idea. I think that you have to be careful. You have to feel, what's up there. Is the liver up there? Is the spleen up there? Have you actively tried to feel for those organs to see whether they're enlarged? And hopefully you can feel in the right on the side there, and feel, maybe a gallbladder acting up or the like. But we do know that people give all of these things like the xylocaine. What do they put in with?
Oh
the
yeah, the
xylocaine?
GI cocktails, right?
Yeah,
Like the lidocaine and the Donatol, and
yes,
you got
yes, the green
Maalox
stuff.
and whatever. Yeah.
And they somehow think that that'll help them distinguish, and the literature says it really doesn't. And it also basically says putting in the lidocaine really is not really helpful. That just giving the antacid will do the job if that's going to respond there. But it's tough, because I think it's probably the toughest spot to ascertain what's going on in the abdomen is upper abdominal pain. So especially central, where it's kind of like right in the middle there. It's not really around any of the solid organs that you have to deal with, and it's kind of like, well, what is that? Is that some gastritis? Is that has the person had this before? It's like you just don't know, and more likely than not, a CT is not going to be all that helpful, because in the center is basically these hollow organs, and hollow organs don't, we don't get that much information from hollow organs on a CT. We're really into solid organs there. So I think it's hard. I think the idea of getting the usual test is probably reasonable, within the constraints of the history and physical exam. You don't want to miss pancreatitis. It's a particularly nasty disease. And I remember a case where the guy was in his 20s and had pancreatitis, and it was like, why? God only knows, but
Right.
he didn't have any of the risk factors. And
Wow.
and pancreatitis is just kind of like you get those enzymes from the pancreas into your bloodstream. It looks like you're starting to dissolving your lungs, and this next thing you know, you've got a really bad, serious, life-threatening problem.
Yeah. All right. Well, let's talk about esophageal foreign body. That's kind of the next place I go in this talk here.
All right, esophageal foreign bodies. Patients have weird complaints sometimes, like bugs crawling out of their skin or their heart hurting, and you kind of take it with a grain of salt. But if their story is, I was eating something, I swallowed, felt something scraping on the way down, and now I feel pain right here, then that's one of those things you can kind of take them at their word for. They are very good. Patients are at localizing damage to the esophagus. You can see some danger areas here as far as places you don't want there to be perforations of the esophagus because of what's next door to the esophagus. So resist the urge of just kind of blindly shoving a nasogastric tube down into what could be a damaged esophagus. What else are you going to ding with that nasogastric tube? You really want to take a good look inside the mouth when someone, especially, is saying, I have this foreign body sensation up there. Especially if the person, look at the middle picture here, is, I wear dentures and I had them in half an hour ago and now I don't know where they are. I found them. So you can often pluck out things from the upper esophagus here, from the oropharynx. What you have to be careful with, though, is this. You have to be ahead of the aircraft. This is an aviation term where you have to anticipate the next thing that's going to happen. So ideally, the next thing is you pull the dentures out of their mouth and they thank you and you discharge them. The horrible thing is they shift, or you bump the dentures down, and now instead of having a pharyngeal foreign body, they have an airway foreign body. Okay? So be aware these procedures and retrieval things are not necessarily benign. Be ready, be ahead of the patient on this one. You don't always have to image the patient if the sensation they're having is just mild discomfort. If there's zero respiratory anything, they're not coughing, they're not having a shortness of breath, they're not just in that kind of distress, they're in some mild pain, I think there is a good risks benefits discussion that can be had if they can swallow well or just in some minor discomfort to having them follow up with GI as an outpatient and clear follow-up instructions for a scope. And that's what's really needed usually is some sort of a scope. I love chicken salad. This person really likes chicken salad, right? They're saving some for later. This is an impaction, okay? So this person often doesn't just come in saying, it kind of hurts right here. No, they are holding an emesis bag, spitting, heaving in the emesis bag. We've seen these patients, some of us have. They look super uncomfortable, and they cannot go home. Often these folks have a history of this, and they know that when they eat certain foods, meat is a common offender. They can get things a little bit hung up, and they have their little maneuvers that they can kind of twist and turn their neck, and often that clears it for them. But often they're coming to you because all those things didn't work. Endoscopic retrieval is usually the way to go. Sometimes CT can be done, but honestly, if they're having an impaction, what's the point of shooting them full of rads when you know if you're not clearing that impaction that someone's going to have to go in with a camera anyways and get that out? So can't tolerate PO, GI's got to see them that day. If you're able to clear the impaction, then they need to see GI in the short order here. Because why? Because some studies suggest over half of these patients, over half, have some sort of anatomic abnormality here, a web or a ring, or God forbid, a neoplasm that is causing the food to be impacted and hung up. So don't let them think that, hey, we cleared it and you're good to go living your life, never seeing a PCP or a GI ever again. No, you still need to go see a GI doctor, even though we cleared it.
Okay, Rick, so you saw on the slide there, red text underlined, early GI consult is advised, except in all my experience with taking care of people with foreign body esophageal impactions, early GI consult is the last thing that we get. We consult GI and we're often told, well, try this medication and then try that medication and then try them again and wait another hour. And if that doesn't work, yeah, I'll be right in. So it's really hard to get GI consult in quickly. I'm going to pin you down here. What if you could pick one medication that actually works to relieve esophageal foreign body impactions, and it was safe to try to get them to pass that into the stomach? What is the one medication you would pick?
That's a hard question because I don't think any of them work. If any of them work,
Right.
We wouldn't need any GI consult because it would just go down. I think all of these have theoretical advantages, and this is an example of where the theory does not necessarily result in the practice occurring, like giving glucagon and loosening up these constricted esophageal muscles. It's like, it's kind of, I've given glucagon and I don't think it works consistently by any means. And, sometimes it makes people vomit, and, maybe that's okay. You're going to vomit, you're going to throw, shoot this thing out. But if it's really obstructed and you're vomiting against it, you're generating a lot of pressure in the esophagus below it. So that's a problem. This is one of those situations where the diagnosis is so easy. They come in with the spit bowl. They cannot swallow their spit. And so you don't need to spend a lot of time documenting where it is or anything like that. They said they were eating dinner, they were eating a piece of chicken, they were eating this or that. So you're right. The GI doctors may want you to do something, and hopefully it'll go down. And I think most of the time, if you give it enough time, and if you sedate the person with, maybe they'll need some kind of opiates to make them feel a little bit better and decrease the spasms of this or that. I think many times things go down and just by themselves, and so we attribute, that what's made it go down, when It's like it was going to go down anyway, kind of thing. So it's really difficult to pick one medicine. I guess the one thing that I would do is basically make a phone call.
Right. Yeah.
Am I,
None, I
am
think
I
none of
allowed,
the above is the
am
best
I
choice.
allowed a phone call, one phone call?
Exactly. Yeah. And you know what? I think it's important to recognize, you mentioned this exactly, like there's a non-zero chance the glucagon induces vomiting in this patient. You know, and what if the patient has a prior history of heavy alcohol use? Might they have some esophageal varices underneath that foreign body? Might they just be an older, brittle patient where you don't want them vomiting anymore? You know, so I think there are certain times in which you may have to gently, professionally push back a little bit against GI. If they're suggesting you try all these different things. Other medicines I've been asked to give are benzodiazepines, which I guess are fine, but there's contraindications. You give benzodiazepines. You could give some sort of antispasmodic like metoclopramide, but those are not benign medications all the time. I am starting to see where GI specialists are saying give sublingual nitro, whether it's just like under the tongue or dissolved in a cup of water and you drink that. A smooth muscle relaxant, I suppose you could do that, but none of these things are without their harms. And so I think you really have to be careful. I agree. There's not great evidence behind every single one of these things, and potential harm is behind them too.
Yeah, I think that it's, plus a lot of these things make the patient, they're really uncomfortable. The fact that they can't swallow their spit and they have this feeling of this ball in their chest, and we're going to just try to wait it out so that the GI doctor can finish dinner and then have come in, kind of thing. I mean, I can understand a little bit of that, but giving this drug, try that drug, it just buys time for the GI guys. I think that they just need to come in and this is generally one of those things where the doctor's going to do what that's what the treatment is to remove it mechanically. And so they know that these medicines generally don't work, but, and you're right. I think that some of them will have some potentially negative effects. People talk about drinking carbonated liquids.
Right. Yeah, that's a good one.
I don't get that. It's kind of like, well, you drink carbonated, it expands well, it goes down as bubbles, and this thing is down here, and you're going to regurgitate this into your trachea because you can't swallow this soda where it's, it's like, it's just messy.
Yeah, it's not a depth charge off of the submarine back in World War II. It's just it's soda, right? It's not like that, explosive and expansive, So,
well, the other thing is, I think if you are going to do that, my personal favorite is Dr. Pepper, because it's a medical soda.
Oh yeah, there you go. Right, exactly. You went to school and everything. Yeah.
Bring on the Dr. Pepper.
We can consult Dr. Pepper. We can go
we
for
have
that.
one can of it in the refrigerator there for these emergencies.
That's brilliant. One thing we've done too in down that vein is we've gotten these effervescent granules. The Easy Gas is one brand name. They're little pop rocks. They come in this little packet. Radiology has them. I've had folks kind of like shoot that with a small amount of water. That does fizz pretty quickly. That's a little more gas forming than I'd say pepper, a soda off the fridge shelf here. So that's something to consider as well. I've had, I feel like just as much success as I've had failure with that. And that's just also just uncomfortable to have this foaming morass come out of this patient's mouth when they're already very uncomfortable. That's just these are all dice rolls with poor odds, just like Vegas. Well, I think this was great that we got to go over some of these things here from our boot camp. Hopefully, listener, you got a feel for what it's like to be at boot camp, and we're going to continue that going on here to finish out the podcast. We'll do a great question and answer session where Martha and I were involved, and you can kind of hear how great it is to be able to ask questions directly from these emergency medicine subject matter experts about the topics they're presenting. Lots of great issues are often raised that aren't found in your textbook or on your social media group here. Let's go on to the 2View trivia question for this past month. It is a two-part answer. We talked that day about how contact lens wearers can be susceptible to more serious eye infections. And one of the eye infections we didn't talk specifically about was something called acanthamoeba. It's a parasite. And so our question was, the naming of acanthamoeba has a Greek origin. What's the Greek origin and translation of acanthamoeba? And in what year did the FDA recall a contact lens solution because of contamination with acanthamoeba? Rick, do you have an idea on this one? Where the origin of acantha comes from in the Greek?
No, I really don't. Acantha. No.
Yeah.
I don't want to make myself seem too out of touch with the reality here, so I'm just going to pass on that one.
I know your Latin is a lot stronger than your Greek.
It is. I went to a Catholic high school where they had 2 years of Latin. Then I went to a Catholic college, and I had 2 more years of Latin. So I'm ready to say mass.
Perfect. Yeah. Well, too bad this wasn't a Latin translation. Well,
yeah,
from
exactly.
the Greek, acantha is spike. And that FDA recall of the contact lens solution was 2007. The winner, rather, is Misty Haltom. From my copious amounts of Googling, I feel like Misty Haltom is a nurse practitioner from Texas. So congratulations, Misty. We'll be in touch with your winnings shortly. Rick, what should we give to the winner of this next 2-part trivia question? It's great to have you on here so you can just tell us what we're going to give this person.
Well, I don't know the magnitude of the gift that you're used to, but the only gifts that I can think of that really, really make sense is giving them a course.
Let's do it. You get a
course.
Free course. And, we have a lot of options in courses here. We'll talk about that in a second here. But here is the 2-part trivia question here. So, again, we just got back from Las Vegas, and the big hospital, the first hospital of that area, is called University Medical Center of Southern Nevada. That was the first one, but it wasn't called that when it opened back in the day. The question is this: what was the first name of UMC, and when was this hospital opened? You're going to want to send in your reply as soon as possible, because we had some stiff competition for our last trivia question here. Send in your answer to 2viewcast@gmail.com. It is always the number 2viewcast@gmail.com. If you also want to get on our website, where we talk about all of our different talks and have kind of like our show notes here, that's at our website. It's at 2view.fireside.fm. Again, the number 2view.fireside.fm. So next, let's just kind of quickly talk about the upcoming courses here. The next one is going to be August 23rd to 25. That's our Advanced Emergency Medicine Boot Camp, and they've got some pre-course EKG and imaging workshops on August 22nd. And I can't think of a better Christmas gift for you or a loved one than December 13th through 16th is the original Emergency Medicine Boot Camp, the holiday edition. That's going to be in Las Vegas again, with pre-course workshops on December 11th and 12th for pharmacology, ultrasound, and procedures. Rick, you usually go to the Key West Emergency Medicine and Acute Care course. Can you tell us about that course? That course is a little bit different than boot camps. Can you talk about what that course is about?
Yeah, the Emergency Medicine Acute Care course was started in 1985 with our first course being in Maui. Since that time, we've done over 500. The focus is, what's the literature say about various questions that are out there? And so it's a literature-focused course that basically we have no slides. It's basically there's a text in front of us. We got the abstracts that we're going to talk about, and we're going to try to basically look at a bunch of questions in a variety of topics, looking at what do we do, what does the literature say, is there any consensus, or maybe is there not, where is the theory, where is the practice, and we like to actually really blow up the cases where there's a physiologically this medicine or this treatment should work, when in fact it's actually given and it doesn't work. So it's like that's always an eye opener, and basically causes you to stop and think twice about just the way things are working in the human body and how complex they are. But the literature is about our brothers and sisters taking the time to study a point carefully. And so the fact that we can take an abstract and match it up with 2 or 3 others that are in the same topic and see, do they all agree, or is there a consensus, or is there not? that's the nature of this course. It's not your typical, okay, let's talk about heart attack kind of thing. It's really about, as an example, we talked about ketamine for suicide last year, and went through all the papers that I could find on ketamine for suicide, because I think we have so little things that we can do for people who are suicidal. And yet ketamine, I know that we're using ketamine for everything, but I think this literature is surprisingly good, that it's a reasonable thing to do, to give ketamine, and within hours, these people are often no longer suicidal. And so we're talking about new things, controversial things, try to advance your practice or reaffirm what you're doing is the way to go.
So if you prefer your palm trees to be of Floridian versus Nevadan extract here, you can come and check out the EM and AC course, Emergency Medicine and Acute Care course. That is going to be in Key West, the last iteration for the year, November 28th through December 2nd. These are ones are rarely in Vegas. If you're not really a Vegas fan here, you guys pick great locations throughout the United States and even outside of the United States to have these courses. Keep an eye out. The locations for next year's course are going to be posted probably the next few months here, and our website for that. Oh, go ahead. Do you have some?
We're trying to do it much quicker, and we're only going to have about 9 this coming year. We already have 6 of them locked down, so we're just waiting to get the contracts on the last 3, and we're going to put it up and let the world know about them as soon as possible. So that they can, if they want to go, they can make the plans that they need to get off the time that they need. These courses, I think that you will find them. I think that you'll come away saying that was really a unique educational experience. That the people who do it are really smart, and generally they're quite entertaining, engaging, and we're only talking about maybe 100 people, so that you can more back and forth can go on. So you can give them a try. The other things we've videoed all of them, so you can take them as a self-study course. So if you're not into traveling right now, or there's too much COVID thing, which is always seems to be over our head, never leaving. The self-study courses are out there, and basically you don't have to travel, you don't have to hotel, you don't need to get off work, et cetera, et cetera. So you may want to take a look and see what they're like.
Yeah, and all these things are available at www.ccme.org. We've got last year's boot camps already recorded. We've got this year's 2022 Emergency Medicine and Acute Care course already recorded and out there. And you can also find us on the little social media outlets too. I'm sure we're going to post our newest locations for 2023 any day or week or month here. Well, Rick, it was a real pleasure. It was great for you to fill in. Of course, our hearts with Martha, and we love to have her back here next episode here. But we thank you for filling in. Not as good looking as she is, but we appreciate the energy and enthusiasm you brought to the day here.
I enjoyed it, and thanks for the opportunity. I think it's really important that we get the word out as best we can regarding the ways to practice medicine that are most pro-patient, most evidence-based, most cost-effective, and that we narrow the variability between us, so that each patient we get to is going to be given the best care that we possibly can, as if the same as if we were a member, treating them as a member of our family, which is always the measure of any question in the emergency department. The always answer is, well, what would I do if it was a member of my family? That always answers the questions that you may be asking.
And I've used that too to a patient, where I can tell the patient or the parent is kind of look at me askance as far as, hey, do I really trust this guy? I said, look, I've got a wife at home, or I've got 4 children at home, and what I'm telling you is the exact same thing I would tell my wife or my child if they were.
It's very powerful, very powerful.
Yeah. It really humanizes what's going on.
Mm-hmm.
It brings it. We're not just a suit or a white coat or a set of scrubs at that point. We are another family member who cares about another patient, and it's really humanizing for us.
You're taking them into your confidence. You're treating them like special. And everybody wants to be treated special.
because they are. Everyone is special that comes into the ER, right? But they're equally as special, right? Everyone is special.
Right. I agree.
Well, thank you for listening to this episode of The Two View. You could subscribe and rate us on Apple iTunes Podcasts, Google Podcasts, and Spotify. We're going to start reading some of the reviews that you guys put on Apple iTunes and Google Podcasts. Spotify, you just get to give like a 5-star. So, hey, go ahead and give us a 5-star on Spotify. If you can't justify that, please write us at 2viewcast@gmail.com and tell us what you want to hear from us on this. We're open to constructive criticism, and we want to make this podcast better and better every episode. Search on those podcasters for a 2View Emergency. That's the number 2View Emergency, and it will come right up. Ratings help us climb the charts so that other clinicians get the same 2View goodness that you got today. If you like YouTube and you want to see the video blog instead with clips, you can see me and Martha talking with the slides in the background, in addition to me and Rick bantering here. Search for Center for Medical Education on YouTube, and you can catch the video version. It often comes out a little bit earlier, so you can get a jump on the trivia questions. Don't forget our website, where you can go next level on any of our topics from any of our episodes, including all the papers and sites we referred to. That is 2view.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett. Show notes are by Meg Dipple. Thank you again, friends in EM, for tuning in. Share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us today at the 2View. Have a good day and a great shift.
So there are a lot of questions in here. A lot of questions
Go for
this
it.
morning. So let's go ahead and pull some of these out. Mike, will you just remind everybody about the alcohol prep pad technique?
Yeah, I won't spend a lot of time on this one. You basically tear open the alcohol pad and you hand it to the patient. Okay, just
Sniff
the
this.
smelling of the alcohol pad can kind of blunt the nausea and vomiting while the medicines take effect.
Pretty cool.
They don't lick it. They don't put it in anything. They smell it.
Yes.
All right, so be clear about that.
Have you found that to be really effective, though?
Oh my gosh, yes.
Yes.
Like, I had somebody.
I have not had good experience with
Really?
it, and I feel like patients give me the eyebrow, like, here, just sniff this alcohol pad. For me, it's
If you look at the studies,
Presentation.
if you look at some of the studies,
You gotta sell it.
It is more effective when combined with another antiemetic. So yes, there's usually
so is
something.
water.
There's something else on board.
So no kidding, I had a patient we admitted to the hospital 2 weeks after bariatric surgery, had a small bowel obstruction, needed to be operated on here. She was miserable. I gave her the alcohol pad when she showed up here, and she's like, what? So, like, really, it is quite variable, but it's worth a try, right? I'm not going to hurt them by having them huff on an alcohol pad.
Did you want
We
to
have
add
to
something?
get that out of the Pyxis.
Yeah.
Any
charge the
drawer,
patient.
any drawer in your ER, you're going to find an alcohol pad.
I don't know. That's what they used to say about bacitracin, and now look where it's
No
gone.
kidding.
All right. Okay, this question. In the instance that a patient comes to the urgent care that does not have x-ray on site with back pain with mild trauma, such as a ground level fall, from a legal stance, should there always be an x-ray performed, even if there is no spinal tenderness as well as no other signs of direct injury?
I think you did low back pain. I would say X-ray is not required if your exam's benign, even if you have with direct trauma.
Yes, I think not only is it not required, but it's very low utility. It's very unlikely to find a fracture if that's what you're worried about. If you're really worried, you should get the CT. I think I have not had a problem with explaining this to patients, and very rarely does anyone just really demand an X-ray. I can't even think of a time that's happened. I don't feel like it's required.
Yeah.
Okay. All right. Dr. S here. I am a family doctor whose institution and ER copies the family doctor on everything that happens in the hospital ER, often with not actually sending the reports. Is there liability to a provider who is copied on a report he has no involvement with?
So that's a great question. We talked a little bit about the break of this. So the short answer is, yeah, I think you have some liability. The argument you'll have is you never establish a doctor-patient relationship. But from what I understand is some of these are your patients, and they're coming out of the hospital and you're copied on things about which you had no involvement in the hospital. The fact that they are your patient and now you know, yeah, you will have some liability. I think that's a very antiquated practice.
Okay.
I think it's happening more and more, though, with EHRs. People are just getting copied on
Oh my gosh,
everything.
yeah.
This next one, what's the best way to handle the texts and Facebook messages from friends and those you haven't seen since high school when they want medical advice? Can this be held against you in court?
I think there's a specific situation that must be tied to this one.
Yeah, well, I responded to this with, I think, a pretty good one. You can copy and paste it if you want. I really, I'm sorry I missed your message. I was at work and I didn't see this. Hope you figured it out. Please see your PCP or go to the ER if you're worse, though. And by the way, hell no, I'm not going to the reunion.
I would answer, syphilis is the great mimicker. Best of luck.
I think it's important to look at your contract. My contract says I cannot treat patients outside of the ER where I work as a PA or an NP. So like, hey, I'm sorry, I get fired if I do this outside of my job. I wish I could help you.
It's a hard thing, right? This is the nurse in the hallway that says, can you look at my kid's ears? Your neighbor who says, oh, by the way, can you just take a peek at such and such?
Yeah.
I don't know, I just have a standard. I just don't take care of anybody that isn't when I'm in the emergency department. You may be a friend, you may be a family. It's not that I don't love you. In fact, it's because I love you that I'm not going to do this. Because not only can you get sued, which you can, but you can make mistakes. You have cognitive errors when you treat someone you know. You just don't see things that you would see clearly in somebody else. So there's a bunch of very good reasons not to do that.
Do you think we're having cognitive errors when we treat each other? Should I stop treating you,
Say
stop
what?
treating me?
Well, actually, I understand the pure answer, but it's often very, very difficult because I think you're a jerk. And please
I don't care.
make me.
I made a mistake once trying to treat somebody I love, and I will never do it again, ever.
Oh.
I don't care. It's just not worth it to me or to them. It's just not.
All right, I'm not responsible for that prescription I wrote you anymore, sorry.
Well, it's one of those things where I really like everybody who's going to the ER in my family to call me first, because I may be able to, in some way attenuate or facilitate their going or not going kind of thing. Because one of my relatives basically went to an urgent care for a sore throat. The next thing I knew, she was on clindamycin. The next thing I knew, she was in the hospital with C. diff, and it was like, she was, 35 years old, and it's like, come on, you should, give me a call.
But you shouldn't have diagnosed or treated her over the phone. You should have said, don't take the Clinda.
Well, I never knew till that she had this an incredible diarrhea. And then she's in a spacesuit for 5 days in a hospital because she's highly contaminated.
I think this is a tough question,
I do too.
and
Until you make a
there
mistake.
isn't always an easy answer.
So perhaps the nuance there is, perhaps you be an advocate for someone who did seek in-person care and offer like, hey, I'll talk to you about what happened, because sometimes there are just things that aren't explained at discharge or disposition, or sometimes clinicians do things that maybe are not reasonable things to do. And so being an advocate for someone after they did the right thing to be sought in person for care, I have no problem with that. I do that a fair amount.
They're just not the primary caregiver.
Yeah, okay. All right, question again for Dr. S. for the info session here. Are there any additional responsibilities for APPs managing patients in the ED with a supervising attending as far as documentation? Example, APP tells attending about a CT finding where radiologist recommends an MRI. Doc says not necessary to order in the ED.
I think the only thing is to document it and say, discuss with Dr. Schufelt, recommends doing this as an outpatient. Patient concurs, patient agrees. Now, there may be some times when absolutely, for the cavernous vein thrombosis, you want to get the MRI, MRV in the ED, and then it might be a discussion, and you might have to take it upstairs a notch, where you call the radiologist back and say, let me put the attending on in the emergency department, because he or she does not believe this needs to be done emergently. And I think from what I read, it does.
I think these are hard. I think for APPs, when you feel very strongly about something and the supervising physician says no, I think these are where your skills as a communicator come in on how to explain. First of all, listen, because they may know more than you do about it, and they may be able to say, well, here's why, ask why. Here's why I don't think it's indicated right now, or here's why I would do this instead. That's helpful, because sometimes we all have something to learn. We can learn from anybody we're working with. But if you really have a difference of opinion and you feel very strongly that the patient will be harmed because of that decision, this taking it upstairs, it often ends up going, it's so uncomfortable. Calling the radiologist isn't necessarily the answer. Letting two people talk to each other may help. Sometimes it's just really uncomfortable, and you might even need to go to the medical director if you feel strongly enough. I mean, we all have foibles, and we're not all of us is, the best person ever in our jobs, and so and again, the whole point is the patient themselves in all of this. So.
I hear with some frequency from PAs and NPs that the doc working will not help them out or go to their cases or review their cases, or they say they're your cases or something. It's hard to believe, but this comes up a lot. Does anybody have any issues with that happening with you?
Hopefully
not.
The
doc won't help you out at all, or they're getting weird about it?
I hear about it. It's not my physicians, frankly, but it's other friends I know who work in the Dallas-Fort Worth area who are told sometimes, hey, that's your pod.
Mm-hmm. That's really too bad.
Yeah.
And they're sick patients, right? I mean, we can handle the bread and butter stuff. This is a dicey patient, a high-risk patient, maybe needs admitted, maybe a consultation. Well, nice to have an attending's weight behind something, and it's not given.
And the patient's supposed to be the most important thing, right? We keep forgetting all of that in our weird interactions.
Yeah, okay. All right, this is another one that Mike and I were actually arguing about over there on the side. And
arguing?
We weren't arguing. We were being really nice to each other.
Collegial discussion.
Yeah, collegial, no.
Oh, this is for UTI?
Yeah. So is a single dose of IV or IM Rocephin indicated for a patient you plan on discharging on oral cephalosporin? I was told no change in outcome. So Mike, you go first on this.
Oh, okay. No, it's not expressly indicated. This is one of those times where there's a lot of nuance involved. Is the patient going to walk out of your ER to the pharmacy and pick up their drugs? Then probably you don't have to give them parenteral antibiotics. Is it late at night and the pharmacies are closed? Does the person work the next day? Are there financial barriers or other barriers to picking up antibiotics in the pharmacy? Well, in that case, maybe you want to give them a 24-hour window to get those medications, to scrape together some money, to get off of work, whatever, and that's why you give the ceftriaxone. You don't have to establish IV access if they don't have it already. IM ceftriaxone just is worthwhile for something like this over IV.
And are you talking about pyelo or cystitis?
Well, mostly pyelo, but cystitis, I think it's overkill for cystitis.
It is.
So you could just give an oral cephalosporin in that case.
And you can always give first oral dose of meds in the ER.
Which I mentioned I kind of do, especially with the whole pharmacy shutting down. But maybe even if it's a lower UTI and the patient's like, I can't go to the pharmacy for 24 hours. Weird stuff happens, right? And so sometimes we have to be a little bit flexible with these things. But I agree, in a perfect world, I would not give parenteral ceftriaxone for a garden a cystitis.
Okay.
Or a sore throat, usually either, or the sniffles for 24 hours.
Here's another good question. Turkey Sandwich Tycoon, great name, by the way, asks, for kidney stones, should I wait to give Toradol until I get my creatinine back, especially if the presentation is vague and I'm going to send them for a CT with contrast?
I answered another thing, but I want to hear what you guys have to say.
I answered as well, but let's see what you guys have to say as well.
It depends. It depends.
Yeah,
In
that's
a
right.
young,
That's kind of what I
healthy
said too,
patient,
Right.
then they're
Sure.
probably going to have normal renal function. I'm willing to take that risk if I have decided already that I want to give them ketorolac or another NSAID, and I think that's acceptable. So it all depends on your level of concern and comorbidities.
Right.
Yeah, go ahead. And to parse that a little bit out, the CT with contrast, if you're worried about stones, you won't be doing a CT with contrast anyway. So I'm going to just pull that out as a little separate thing. For stones, you don't need contrast.
Their thing was that it was
was
a
vague.
vague presentation, so you're just
So
like,
they're not-
I guess I'll get it. with
Could be kidney
contrast."
stone, could be something else. But the other thing is morphine is a great drug to treat kidney stone, renal colic pain. So, I mean, I like it, I use it, and then you can always add the Toradol on after if
But
you're concerned.
what if you work in an opiate-free emergency department?
We'll talk about that later.
That's
No,
later.
I won't go there.
Actually,
You
this-
can see the for your kidney
yeah.
stone.
Yeah.
And
good.
this
Here's
is
a hug.
one instance where I actually do sometimes err on the side of adding a little fentanyl first, because it's so miserable to have a kidney stone, and they will be better with fentanyl within a minute, and then the morphine lasts the 5 hours. And
So, yeah, Diane, you talked about that before. You have a love of fentanyl for these acute pain issues, and
For overwhelming
intranasal as
pain.
well you can use, right?
yeah,
So,
lots of ways.
lots of ways. Okay. Okay, the esophageal, is it coming up here?
It's not up there.
Slide out. Sorry about that.
CT abdomen with pancreatitis?
Go ahead and let's do this one and I'll fix this.
There's the EMTALA question too. I'm
Yes.
just defining
Okay.
what is
I went
EMTALA.
Let's define
Yeah.
EMTALA. Someone did ask about that.
So EMTALA's Emergency Medicine Treatment and Labor Act started in '86, mainly from hospitals in Texas and probably southern Arizona, getting people who are undocumented coming over in labor and shooing them down the road to the community hospitals. These women were dying en route and delivering en route. That's kind of where it started. And then the follow-up question is, how does it apply to private emergency departments? If a private ED accepts Medicare patients, then they are governed under EMTALA. If a hospital has an urgent care on premises, or if it's owned by a hospital, they too are governed under EMTALA. Meaning everybody gets an emergency screening exam before you can ask about their ability to pay, regardless of their ability to pay.
And it's expensive if you don't do it, for both you and your hospital,
Yes, 50 to 200,000,
individually, you and them.
not covered by MedMail.
So this other question to piggyback off that was, how does EMTALA apply to private ERs? Kaiser is members only, and community hospitals will discourage patients from Kaiser to be seen in their hospital. They still have to see the patient.
If they take Medicare money, they have to see the patient, they have to
Yeah.
do an emergency screening exam.
So.
Just err on the side of just doing it.
Right.
It just, I mean, it's kind of
easy.
the right thing to do anyway, but err on the side of, and if you're being pushed to not, push back. This is a big pushback. Your hospital knows this. Your CEO would want to know if you're being told not to screen, because the hospital is going to lose its Medicare contract and pay a fortune.
Let's end with this last one.
I want to throw in something really quick with
sorry.
EMTALA, just because it was asked. If you have a patient who's a pediatric patient, right, there's all this concern about like, well, do we have consent to do anything here? You are still required to do a medical screening exam for a pediatric patient, even if you don't have consent from a parent. The consent is for treatment. You can hold off on non-life-saving treatment, but you should evaluate and do a medical screening exam regardless of what consent you may or may not have.
Okay.
Got it.
Last one here. What's the best way to document refusal of informed consent without using AMA?
That's mixing things.
So
Like
I
a
would just go
form.
through those kind of 9 bullet points we talked about. Do they have capacity? Do they understand? What have you? I document all of that, and then it's like going to the auto mechanic analogy that I use. I document a patient has capacity, they understand the risks and benefits, they elect to do this. It's all good. And I rarely, if ever, make patients sign out AMA. One, most people's insurance won't pay for you if you sign out AMA, so you really punish the patient when you do that. Also, it just looks retrospectively that you're like this with them instead of like this with them, embracing them. Because everybody has the right to decide their own care as long as they have capacity, and I just approach it that way.
I thought that was a myth about insurance declining to pay for visits if there was an AMA form.
I've seen that recently.
Wow.
That, hey, you walked out, you didn't get treatment, why are we paying for it? Now, maybe it's some insurance plans, maybe it's Arizona. It's probably not Medicare, probably not Medicaid, but I've seen some private insurers who will say, no, they didn't say for treatment, you're paying.
The other thing is that you ought to, if they are going to leave, do your best to give them some medication. If it's an infection, you give them, you don't say, okay, I'm washing my hands. You do your best.
Yeah.
So if they're having chest pain and you can give them a beta blocker and some nitrates, if that's the best you can do, okay, we're going to do that kind of thing. So you don't abandon them, and you basically say, we're here 24/7. You change your mind, please come back.
That's a great point. I've seen a lot of cases with AMA, the provider does, you're done,
Yeah,
not
it's not
talking
good.
anymore, as opposed to saying, okay, I know you don't want to be admitted, I know you don't want this, but if you must go home, if you insist on going home, here's what we're going to do to help you.
And we're always here, please come back.
Exactly.
You're always welcome.
You can also say, would you like to see one of my colleagues instead? And I've done that before and said, maybe this just isn't a good relationship, maybe we're not communicating well. And I have no problem having them see someone else or get a second opinion or whatever they want. So to keep them there. Diane, rapid fire, you like to do this, yes or no's?
Put me on the hot seat. Okay, go.
Can you assume if someone has tolerated fluoroquinolones in the past that they're unlikely to experience black box symptoms with future prescriptions?
No.
That's a no.
No, I have a little thing
These
about
are yes,
this.
no's.
He can talk. Let him
I'm
talk.
kidding.
He's the boss. He can
I'm
talk.
kidding.
All right, you shouldn't be prescribing anybody fluoroquinolones. If you read or look at the most recent black box from May 16th, there's always an alternative to the fluoroquinolones. Use something else.
Yeah, your urologists are going to ask for it. I guarantee they're
Yeah,
going to
well,
ask for
we have to give them, have them help them read the black box on the neuropsychiatric effects of fluoroquinolones.
All right, just this last one. What about sublingual nitroglycerin in your facility if they don't have IV form?
So I'll tell you, the best situation you could ever end up in to look like a rock star is have somebody go into pulmonary edema while you're on an airplane. Because you end up having to figure out what to do without your IV drip of anything and get on the overhead and say, anybody have any nitroglycerin here on that plane? Can anybody with nitroglycerin please bring it up to the galley with the flight attendants?
That was very accurate.
Because you can actually give sublingual nitro, it's high dose, it's actually pretty high doses. You can just give it one after another after another.
Yeah, I was telling them about the Germans who first discovered that giving a handful of nitro sublingually treated pulmonary edema.
But it's amazing. I have a
Dr.
friend who
Blissman.
basically went on a 4-hour flight, keeping the patient basically as stable as possible, just spraying, because they couldn't land, they were over water.